Thank you, Ms. Ross. Let me begin with you, Leanndra, about the Southcentral Foundation Land Transfer Act. You have shared with the committee the current conditions of the Quiana Clubhouse. We understand that. Can you just share what the challenges are then with maintaining or upgrading the facilities when South Central does not own the land or facilities? And then I'd also ask you to give a little more clarity to what you just said at the end, which was you're prepared to move quickly, and if you could just describe what quickly means in terms of your ability to move should this land conveyance happen.
Thank you, Chairwoman. I appreciate the question. Thank you. The Quiana Clubhouse is in a 50-year-old building, and it has many of the challenges, as you can imagine, that three closely connected buildings would have. Heating systems are difficult to maintain. There's just participants walk outside to get to the different services located on the facility. This facility is one that we would love to see increase for our customer owners. We'd love to be able to build this summer. We are at currently a 35% design for the building. We're ready to build, and it will.
So if I can just ask on that, you're ready to build 35% design, but the thing that is holding you back is you do not have the warranty type.
Right. We do not have ownership to the land. Yes, and so we just would like the ownership through this land transfer to be able to build.
And if that is to come through this conveyance, you are prepared to move to start construction this year.
We're excited.
I can tell you're excited,
Yes.
and rightly so, and I know that those who serve are probably equally excited. And the importance in terms of being able to be more responsive for the increasing demand for behavioral health services in this area, I think is so important. So I just wanted to make it clear for the record that you are ready to go. The only thing that is holding you up is the full ownership of the property itself. And that, let me ask one other question, because it's always important that you have stakeholder buy-in,
Yes.
whether it's from the community. Can you just speak to the efforts to work with local stakeholders to prepare for the land transfer?
Yes, thank you. Good question. We have many partners, and the community in the area is very excited about the new building. We've gone to community councils. We've shared with the municipality our plans to move forward. We have letters of support from community partners. And I think that we've been a good neighbor in this area, and so we'll continue to be a good neighbor in this area.
Good. I appreciate that.
Thank you.
Let me ask you, Mr. LaRoche, because you have mentioned that, well, you support the conveyance. You noted a concern here. Congress has already passed several bills transferring federal land to tribal health organizations. In 2022, we were able to pass legislation that conveyed IHS land to the tribal Tanana Tribal Council, TCC, to the Southeast Alaska Regional Health Consortium, as well as ANTHC. So you've mentioned that you have some concerns, but can you tell the committee, when IHS carried out these transfers 3 years ago now, back in 2022, did the agency have any administrative difficulties in executing on them?
Thank you for that question. No, we had not had any administrative problems with that. We prefer the quit claim, but
sure.
But we enacted in law. We will go through with the warranty deed.
So,
yes.
so I just want to make clear then. Well, we get what the preference is. even though you didn't have that preference with these other transfers, the agency didn't encounter any difficulties then with that legislation.
No, Senator.
With how the deeds were titled. Okay. Let me move to you, Ms. Seymour. You have shared a great deal in your testimony today. The issues when you have PRC payment delays leading to these unexpected bills, medical debt, credit score impact, and you went further to say that in an effort to perhaps avoid this, you actually have some of your Colville tribal members avoid seeking medical care altogether, which is absolutely the wrong direction for any of this. So you made a decision. You made a decision back in October of 2025 to assume all IHS functions through a 638 agreement. To what extent did these concerns that you have raised, people who were fearful of debt collection issues and thus delaying perhaps medical care or treatment, you have also just detailed how this concern about what it's going to mean to me when I have the bills coming to my house. I'm dealing with a bureaucracy that I may or may not be very comfortable dealing with. To what extent did these debt collection issues affect the decision to contract IHS functions and take on the management and the provision of healthcare services yourself?
It had a huge impact on that decision. We were getting complaints, we were losing our people because they were not getting the care that they needed in a timely manner or not at all. And I believe the council has been looking at it for years and finally took the stance of, you know what, we can do better. We can, if we contract this and bring this under our supervision, we can provide our members with the health care that's needed. But like in the statement, it says we can trace this back to deaths in our communities. I can give you one example of some issues. I had a family member who was awaiting a specialist referral, and her appointment, I believe, had to be canceled. She was going to have the follow-up that Monday. She died over the weekend of a massive heart attack because she couldn't get to the doctor soon enough to be checked out. And she wasn't the only one. There were many instances where that happened on our reservation, and we decided that, you know what, enough is enough. We can't continue to lose our people. So that's why we made the decision to contract. Not only that, but also I myself have been sent to collections. I have bills. My husband has bills right now that are in collections. My daughter does and we diligently turn them in time after time, but they weren't being taken care of. And so what do? You don't want your credit to be affected. So if you have the means, you pay it. And a lot of our patients are elderly, and they were paying these bills out of pocket when they couldn't afford to do so.
So even though we've heard Mr. LaRoche say, look, the patient is not going to be liable, that reimbursement comes, you still have a situation where the debt collector is the one that comes before the reimbursement comes. And so there's concern about whether or not the reimbursement is going to be made, whether it's going to be made timely. Mr. LaRoche, you said something about, on this issue of reimbursement, that it's reimbursed to the extent of the PRC, and that the patient should be cautious in not exceeding the amount of the PRC. How do I know what that amount is?
And that's a great question. It would have to do with whatever that service is that they were sent out for, as far as usually the PRC program is paying providers, so that's what we're used to doing. So,
right.
Yes, the patient wouldn't necessarily know what that reimbursement rate is.
That's the heartburn that I've got with all of this, is you're putting the burden on the patient. If I'm going to go in for a mammogram, all right, and I don't necessarily check to see if the cost for that procedure in the area that I'm in is within the scope of what is approved within the PRC, and you're saying, all right, you're not going to be on the hook ultimately. But it could be a situation where we don't know how long that reimbursement is going to take. And in the meantime, who knows? It gets sent to a debt collector. We don't know. But then you find out that not the full amount is going to be covered. And it just seems to me that we are doing a huge disservice if we're saying there is a federal trust responsibility here when we're talking about health care for Native peoples. And you've got a program that for reimbursement for care that assumes an awful lot that is not very clear. You're nodding that you don't disagree that this is confusing to the patient. Do you have any good suggestions as to how within the department this can be addressed? I think that perhaps Senator Round's two bills could be very, very helpful to that.
Definitely. The PRC program at IHS has always been set up to deal directly from IHS to a provider, so that's why it's a little bit more confusing when we start talking about a patient having to pay on that. But I think this is an opportunity for us we'll be more than happy to work with the committee and the drafters to come up with some technical assistance and come up with a solution on that.
Okay. Ms. LaRoche made the observation that there's nothing in statute or regulation that prohibits reimbursement. CBO apparently thinks that there is some budget authority that is required. This is something that, again, I think needs to be made much more clear than we currently have in statute. We're in agreement on that? I'm going to ask my last questions, and I'm going to turn to my colleagues who have just come back because they've done their second vote and I have not. You have mentioned the issues that the burden of a 72-hour window creates. Senator Rounds had mentioned that as well. Do you think that people understand that this 72-hour reporting issue is a problem for them, or is that just an issue with the providers themselves? Yes, please, thank you.
So it's an issue I don't think everybody understands, and I think that's where it would be helpful for more education to the patient. But I think it's very cumbersome, like Senator Rounds had said, because if you have somebody who is in an accident and they are in ICU for 2 weeks, that you're limited to a 72-hour, but within those first 72 hours, your family is so focused on if you're going to live or not. The last thing on their mind is calling IHS to report to the PRC department that they're in the ER. And at that point, you don't know if they're going to stay at that hospital or be shipped to another, and then there's repeated calls that have to be made. So I think the 15 days would give a lot more grace time for the families and for the patients, because I think the first 72 hours of any illness is critical to taking care of yourself or your family member who's in the critical illness and in that time frame. But I think part of it is that patients don't quite understand that, and so it doesn't get reported, and then they get released from the hospital, say it's in 4 days, and then they call, and then it's too late. So now they're stuck with this astronomical, ER or hospital stay bill that they have. Because attached to those bills also, like we're in a rural area, so if you get life flighted or ambulance, that's attached to that bill as well too. So if you don't report that, that could be $200,000 to $400,000 depending on where you're flown to. So.
Senator Cantwell, we'll turn to you, and then Senator Lujan after that. I think Senator Schatz is coming back. I'm going to go vote. But I think Senator Rounds has presented a couple really strong bills on how we can improve purchase and referred care. But we've heard some really very interesting testimony here today in terms of how a system that should work better, that should ensure that Native American patients, when they go to seek care, are not ultimately on the hook, but it's some pretty troubling stories. So I think we've got some good suggestions out there, and then Ms. Ross from Southcentral Foundation working on great initiatives when it comes to the opportunities for access for mental and behavioral health. So I'm going to turn it to Senator Cantwell next, and
Thank you, Chair Murkowski. Thank you for you and Vice Chair Schatz for holding this legislative hearing. And the chair just mentioned Senate Bill 699, the Purchase and Referred Care Improvement Act. I was glad to join Senator Rounds on that. I want to thank Councilmember Seymour for traveling all the way from Colville to be here in Northeast Washington. So very challenging to get all the way across the country, particularly. We just had some people in the office from Oroville, and I was like, how'd you get here? So everybody, a lot of traveling this week. So I teamed up with Senator Rounds because introducing this Purchase Referred Care Improvement Act, really after hearing from the Colville tribe. It was just really clear the pervasive problems. If you're in this rural part of the state and IHS is supposed to deliver care, but IHS doesn't deliver care, and then your people end up getting credit score deterioration, how are you supposed to get health care? And it's all because Indian Health Services was not paying its bills. So as we already heard from the council member, the Colville Reservation, which encompasses 1.4 million acres, so no small area of geographic area to serve in the northeast corner of our state, there are no full-service IHS hospitals and a 60% vacancy rate at Colville IHS service unit. Now, that's basically abdication of duty, if you ask me. It's just abdicating the duty that we are supposed to provide for health care. This means tribal members often travel long distances to seek the health care providers outside of the IHS system. And the IHS system is supposed to reimburse the health care provider for those services provided to those tribal members. Unfortunately, when this doesn't happen, IHS does not reimburse the health care provider, and then the provider is not paid, and then they seek payment from the tribal members. So that's what we're here to try to say. It's got to stop. It's got to stop. We can't be putting this on the backs of individual tribal members. This is crazy. Live up to our responsibilities in delivering care, either through the IHS system, or let us go get care and pay for it. That's the role and responsibility here of the federal government. So tribal members, including elders and elected officials, have been sent to collection debt creditors. So literally, we're not providing the health care, but then we're letting debt collectors prey on individuals. So the Colville tribe recently learned that there was a $42 million in funds that should have been spent on health care for tribal members if only IHS had administered the program properly. Recently, the Colville tribe assumed all IHS functions under the Self-Determination Act. And I must say, I'm so proud of our state where we have become the primary provider under self-governance of clinics around the state of Washington. Not only are they great tribal clinics, they are serving the larger population within a region. Oftentimes, they're in some of our remote parts of our state, like the Macaw or the Lummi or something of that nature. And not only are they providing great Indian health services, but they are providing care to the larger community and really becomes a stabilizing force for healthcare within the region. And obviously, Indian country, because it's been preyed on for the most egregious abuses of narcotics, with people locating big fentanyl centers. Why do they locate in Indian country? Well, I just said the vast land that basically is there at Colville or somewhere else is because you can't cover all that land. You can't cover all that tribal land. You can't cover. They know that tribal law enforcement is challenged to deliver and root them out. And so we've had horrific challenges just dealing with the attack on Indian country by the scourge of fentanyl. So, Councilmember Seymour, again, thank you so much for being here to illuminate this. I wanted to talk about how the Purchase and Referred Care Act does support Indian country. And since IHL's healthcare services, since the tribe has taken over and has your own relationships, are tribal members financially getting better protection?
So tribal members are financially better protected under the Colville Tribal Healthcare Authority because our purchase referred care payments are issued faster and more reliably than under the IHS system, which is reducing delays, denials, and unexpected patient bills. We're also able to build and maintain financial reserves for our programs, which strengthens long-term sustainability and protects services during funding challenges or emergencies. So that, combined with stronger revenue cycle oversight and local decision-making, tribal control has shifted financial risk away from our members and towards a more accountable and sustainable healthcare system.
Thank you. Thank you for that leadership that Colville is demonstrated. And again, if we can just continue to empower, I think through self-governance, the delivery of a system, I think we're going to get a better system. But on this issue, Mr. LaRoche, is there any legal impediments to IHS reimbursing tribal members who pay PRC bills out of pocket so that they can stop being harassed by collection agency? Is there any legal impediment to that?
Great question. I'd have to take that back to the legal as far as from the legal side of things, but I do know one of the things that's challenging for us is we are bound by the federal acquisition regulations, and sometimes that's a little bit cumbersome for providing payments for health care and still complying with
Burdened
that.
by what?
The federal acquisition regulations, the FAR, requires a purchase order, so it's a little bit more cumbersome when we'd have to really work with the tribes and IHS to come up with a mechanism to actually.
Okay, so why haven't we done that yet? Is my question.
That's one of the things. If this is passed, we can go ahead and do that.
Why can't we do that right now? We know that we have a broken system in a big part of our state, and why can't we figure out, why can't IHS, if they're not going to deliver the care? I mean, obviously these are choices, right, that people made a long time ago. I'm assuming. I know lots of lawyers in the audience who know this, are back here on the dais, who know this better than I do. But, I mean, different parts of states made different choices, right, whether through self-governance or IHS. But if IHS now can't deliver the care and the tribe is now taking on the financial responsibility of delivering the care, and you have a direct relationship, I'm assuming, because you can't deliver the care at IHS, that you are then contracting with them. So if you're contracting with them, why can't you just protect them from being preyed upon by creditors?
The IHS PRC program was really set up for the payments between us and the providers. So that's one of the things, and we are working we do have a director's work group to improve PRC, and things like this have been talked about there, so we can take those suggestions.
I will get with you. You should go back, get an answer, and figure out why we can't do this sooner.
Okay.
All right. I'm not really chairing, but I'm passing on down to Senator Lujan. Senator Lujan.